There's tremendous research out there that clearly defines the things that really make us happy in the long term. And I would encourage all listeners to spend a little bit of time, read some of that literature, and then structure a negotiation in a way that allows you to emphasize and prioritize the things that are actually likely to make you happy.
Dr. Palmer, I think today we have an amazing topic that we're going to go over. It's going to help a lot of us. And it's really about how to handle employment contracts as doctors. I don't know about your experience, Ned, with your first employment contract outside of residency, but mine was a little rough. I didn't really know anything, and I honestly didn't even know the right questions to ask. I did find an attorney that kind of knew, but it was stressful. I don't know, was that similar to your situation?
No, because you were smart enough to find a grown-up to help you. I did the DIY method, which was a terrible way to go. I left fellowship and stayed in the same division. So who am I even negotiating against, right? I'm negotiating up against my bosses that had been my fellowship directors for the last several years. So I was given a thing and just took it. I didn't negotiate CME. I didn't negotiate shift structure. I was given a rubric and just kind of, I don't even remember signing it. It was that inconsequential, but has been like the driving contract for the last 4 or 5 years of my clinical practice. So you did the right thing in paying attention to it and trying to find a grown-up.
So it is going to be great today to talk to not only a doctor who gets asked a lot of questions about employment contracts, but also an actual attorney who specializes in employment contracts. I have a lot of questions, Ned. I know you do too. So let's get to the interview.
Let's get to it with our friends, Josh Daly and Jillian Vestal.
We are very pleased to welcome two fantastic guests today to the podcast for Doctors by Doctors. First is Dr. Josh Daly, who is a practicing pediatric cardiologist at Arkansas Children's Hospital and the University of Arkansas for Medical Sciences. He serves there as the program director for the Pediatric Cardiology Fellowship. He also co-directs a medical student course, Personal and Professional Financial Essentials for Physicians, which equips fourth-year medical students with the essential knowledge and skills to manage their financial futures. He and his wife, Lauren, are parents to 4 children, Will, Caleb, Abby, and Ellie, ranging in age from 13 to 3. Dr. Daly, we're very excited to have you on the show today.
I'm excited to be here. Thanks so much for having me on.
And we also are joined by another guest, Jillian Vestal, who is a licensed attorney that specializes in doctor employment contracting. She received her undergraduate degree in public relations from Harding University and then earned her JD at the University of Arkansas Little Rock. She previously worked in the office for former Arkansas Governor Mike Beebe and then for the State Department of Health. After leaving the public sector, Jillian worked in government relations for healthcare clients and later as a staff attorney for a health system. In that role, she was involved in lots of things, including compliance matters, fair market analysis, and contract review, among other things. Jillian has reviewed contracts for doctors across the country in various specialties, helping them better understand their contracts and negotiate the best deal for themselves. Jillian, welcome to the podcast.
Thank you for having me. Glad to be here.
So we have lots of questions, Ned and I, on doctors getting jobs, doctors agreeing to contracts or not knowing what's in them. So we have lots of ground to cover. But maybe, Josh, if we could start with you, I'd love to hear about your story as a physician and the issues you had with, negotiating your first contract or looking at your first contract and your first job. Tell us a little bit about that.
Sure. So like many of the listeners, I went straight into college and med school out of that and didn't take a single finance course throughout my formal medical education. I started to become interested in finance toward the end of fellowship and read a little bit, but still it was a lot I didn't know. And then it came time to look for a job. And I had a vague sense that there were some jobs available, and I'd heard from a few graduating fellows about what they had been offered, but had no idea what the normative data was for my field as a whole. Didn't have a sense for what the job market looked like in terms of jobs available. At the time, I was training in Cincinnati Children's and was originally from Arkansas, so I was interested in coming back and had an interview. Had a wonderful interview, spent most of the time talking about the job and the people. And at the end of the interview, I was told that they'd love to have me come and they'd send me a contract in a month or so. And we never talked about salary. And then About a month later, I got an email and there was an amount in there that was a lot more than I made as a fellow. I was pretty excited about it, but didn't really have a frame of reference for how reasonable of an offer that was. And so I decided I should probably ask for something. So I asked for an extra $5,000, which was somewhat arbitrary. And they ended up giving that to me. But that was the extent of my negotiation. And then I jumped into the job here. I'm so grateful to be here, work with really great people in a fantastic place. But as I have progressed through my time in faculty, I've learned a lot more about the nuances of physician compensation, what is reasonable to ask for, what is not reasonable to ask for. And I recognize that I did miss a little bit of a window on the negotiation and on the front end, but I've since learned a lot about the nuances of how physician pay is structured here. And in particular, within academia, in the way that things are structured at UAMS, I'm highly incentivized to go up for promotion and as early and frequently as possible. So pay is very closely tied to academic rank. So I did that. And then additionally, pay is in part tied to RVU productivity, although that's a moving goal. I remember at the end of my first year as an attending, I'd got no data. And suddenly I got some Excel spreadsheet that was really hard to interpret, had a bunch of numbers on it. And then my chief just said, "Oh, don't worry about it. You're doing fine." And that was the extent of that discussion. And there was no discussion how exactly my pay was tied to that or how much above the national average I was doing. And so I did a lot of Googling and kind of figuring things out on my own. So fast forward a few years, I became more and more interested in finance. I read everything I could get my hands on. Pretty soon it was clear that I ended up knowing more about finances than the vast majority of physicians around me, which isn't saying a lot. But I became the source that people came to for advice. And so I started giving lectures to residents and then fellows and medical students. After a few years, I ended up directing the finance course here at UAMS. I've written academically on this subject, become very, very interested. And one of the themes that continues to emerge, I talk about the basics of investing, how to negotiate on the front end and all these types of things. But the things the residents come up to me over and over again is, what should I actually ask for? What is reasonable in the field of pediatrics, pediatric subspecialties? And so in the last few years, I've become the go-to source within our hospital, whether someone's getting a pediatric emergency medicine job or a general pediatric job in small town Arkansas. They come to me, they want me to look at their contract, what's reasonable, what's not. And I've had conversation after conversation. And what's really surprising to me is there is salary data available that our institution has, and none of the physicians seem to have any access to it. I have discovered the person in my institution that gets that, and I just basically harass them until they give it to me every single year because I know exactly when it comes out. And I just send email after email, and they give it to me. And then I disperse it among others and help them sort that out. But it hasn't been a direct path, but rather one in which I've tried to navigate my own life, and there's a lot of learners around me and have developed some knowledge and expertise out of need as opposed to intentionality with a plan to develop expertise in that area.
And that's amazing, Josh, because that does resonate with me in my first job out of residency as well. I didn't really counteroffer. It looked like a big number, and I was super happy just to make some money and not be in training anymore. And I'm interested, though, Jillian, I mean, with you working with lots and lots of doctors across the country, how does Josh's story compare to the average doctor you see coming into their first job?
The first part of his story, I would say, is what I hear more often than not. I think, Dr. Daly, you are certainly unique in the latter part of your story. But I hear from doctors over and over and over just that. I got a number. It seemed really great because it was so much more than what I had been making. And they signed the contract without really asking too many more questions. I think, and the three of you certainly can speak to this better than I can, but I think there's also part of that culture coming out of training where you just don't really ask a lot of questions. You do what you're told. You don't want to be seen as causing problems or kind of being the squeaky wheel. So it's a big number. You sign it and you move along, and you don't ever really look at the contract. And then things start to happen that you don't really have a good understanding of. You don't really know why at the end of year one, your compensation went down. You don't really know when it's time to leave that job, how you're supposed to do that, who you're supposed to tell, and how long ahead of leaving you're supposed to tell them, and all of these other questions that exist, even down to where you're going to be working sometimes. Those questions come up. So it's absolutely a story that I hear very, very frequently. And then when working with doctors who are maybe at the beginning of that stage, who have not yet signed a contract, but have been kind of presented with this document that they don't understand with a really big price tag attached to it. What I end up doing is a lot of kind of unraveling that and unraveling what's in that document, and then walking them through. These are the appropriate questions that you can and should ask. A lot of it truly, I think, is empowerment, is telling doctors, this is information that you should know. It's information that you are absolutely rightfully asking for. It's not something that you have to be hesitant about, or frankly, in some situations, almost scared to ask.
How do you reconcile some of that scared to ask? Because as Josh knows, Michael and I are at least half pediatricians. Maybe some of the least successful negotiators, just as a rule. And part of that is due, I think, because of the geography of pediatrics is so concentrated, right? Like Josh, for instance, you wanted to go back to Arkansas. And so that means there's UAMS. It's not like in Boston, there was Boston Children's Hospital. Like there's not that diversity or that feeling of where you can actually negotiate against other organizations or institutions. So how do you know, Jillian, like where that line is, and how do you know where to advocate for yourself, and how do you know where you're accidentally kind of closing a door? Given that, especially in some concentrated subspecialties like Josh is in, there's just not that many options.
Absolutely. It's that's a really great question. And again, a question that I get versions of a lot. The starting place for my answer is to understand the difference in clarification and negotiation. A lot of doctors seem to be kind of concerned with the number of questions. If they've got a list, they don't want to have too many bullet points on the list. I think what's more important is to think through where are the places I'm asking for a change, and where am I just asking to better understand? I don't think you should ever hesitate to clarify something. If you don't understand part of your contract, you need to make sure that you are fully aware of what you're signing. So that's, I think, the first step is always clarify, hey, this doesn't make sense to me. Or maybe even, hey, this is different than the conversation I had when we first talked about this job. Can we walk through what this means? In terms of the negotiation piece, because there are going to be some things that you are asking for, right? We want more money. We want a different schedule, a different location. We want them to pay for tail coverage, any number of things that we see. I will say that I have reviewed many, many, many contracts. I have seen an offer rescinded just based on questions asked one time. And it was a pretty extreme circumstance. Frankly, on the part of the employer, not really on the part of the doctor. And I say that because I get that question so often, and it is shocking to me each time. But it's the question of, well, if I ask this, are they going to get mad and take the offer away? So I don't know where that came from in the within the community, but likely no is my answer. What I frequently say in response to that is, they may say no. If you ask for more money, they may tell you no. They may tell you they can't change this or won't change this. But it's not typically the answer that they just say, you know what, never mind. Now, that all being said, if they offer you $300,000 and you come back and say, I won't take less than $1 million, yeah, they may go, you know what, this isn't the job for you. So I think it kind of matters what you're asking for, and is it reasonable, and is it within the scope of what they're looking for, and does it meet the position description and all of that. But in terms of just saying, hey, can I get a couple more dollars per RVU? Again, they may say no, they may counter, but I would not be afraid of them just pulling the offer altogether.
Yeah, I mean, I'd love to spend a few minutes talking about, frankly, some of the psychology of medical training. I know this is a thing that Josh and I have spoken about, Michael and I as well, of like why are we poorly positioned for this specific moment? Because I think there's systems. Look, I'll use my own examples. I use this one all the time. Our group renegotiated, and at a pediatrics hospital, we were told that if we pay you more, the children get less. So you're up against trained negotiators, right? Like, who will use emotional manipulation and use these like tricks and tactics against you, basically. But there's certainly something to the field itself and then the training. So, I mean, Josh, I know this is something you and I have spoken about before. Like, I'd love to hear your thoughts on like, why are physicians in this position where they come to Jillian like afraid to advocate for themselves?
I think there are multiple factors that contribute to that. Some of those are deeply embedded in the culture of medicine, in which there's this belief that all doctors enter medicine primarily to help others, which is the primary driver, but that it is inappropriate to think about our own self-interest, to advocate for ourselves, or to talk about money. That, oh yeah, we'll be taken care of, but you're really doing this for your patients. And in our case, for the kids, which is even a more compelling case than just patients in general. So there's some embarrassment about talking about these subjects and these messages that may not be explicitly communicated, but are clearly embedded in the culture in which it's inappropriate to ask. Then that gets exacerbated by the hierarchy within medicine, in which as a trainee, you are taught to do whatever you're told, to work a 24-hour shift, to stay late, to see that extra patient with a smile on your face. And you don't complain, you don't push back, you certainly don't ask for additional compensation. And so suddenly you're nearing the end of training, and this same boss who you've been indoctrinated to just do whatever they tell you says, hey, here's this offer. It's a lot more money than you're making now. And you feel no freedom to push back against that whatsoever. So that certainly plays into it as well. And then there's an interesting psychology that I think is helpful to understand the situation. And it was proposed by Dan Ariely. And it's this idea of social norms versus market norms. And it's something we're all intuitively aware of, but it has tremendous explanatory power in understanding why trainees feel so uncomfortable asking for things. And that's this idea that there are two different sets of rules. One set of rules that govern our social interactions, and another that govern our market interactions. So for instance, Michael, let's say we jump back, you and I are in residency together, and you need to move. And you're a resident without a lot of money, so you ask your buddies to come over. You ask me to come and help you move. What am I going to do? I'm your friend. I'm going to feel obligated to do it. I might kind of hope, well, I was working that day and could come up with a good excuse. But if not, I'm going to probably do it. And I'm going to come over. I'm not going to ask you for a contract. I'm not going to ask you for an hourly wage. I'm not going to ask for additional coverage if I'm injured in the midst of doing that. And then I'm going to help you move all day. And what are you going to do? You're probably going to provide some pizza, because that's what you do for people moving. And then at the end of that day, you're not going to come up to me and say, Josh, you did a really good job. I'm going to give you a tip. Here's an extra $100 for your hard work today. Thanks so much. No, that's not what friends do. Now, what will happen is then a few months later, when I need to move, I'm going to ask you, and you're going to feel deeply obligated to do the same, because there are different principles at play. Reciprocity has a huge impact in these social arrangements. Now, however, let's say you paid a company to do it. You're going to sign a contract. You're going to make sure they're insured. There's going to be an hourly rate. And at the end of the day, the person who is going to expect a tip. That's market norms. There's a completely different set of rules that govern those interactions. And so there are some cases in which we're clearly in one domain or the other. And then there's a lot of gray. And the scenario in which you are interviewing for a job, especially at your current institution or with a future boss, is the gray. So you have a relationship with your boss. You're in this social norm category, but then you're discussing market norm topics. And so you can feel very uncomfortable asking for additional things, not trusting your boss, asking for something in writing. And so it's a really difficult place to be. And so you have to be intentional about which space you're in and which set of rules you're operating according to. And then you have to be careful that you're not giving nonverbals you're in one space or in another. Anecdotally, a lot of corporations get in a lot of trouble when they use all this social norm language to imply, hey, we're a family, we take care of each other. And so as an employee, I'm hearing all these nonverbals that we're operating in the social norm category. And then suddenly I'm sick and I'm out, and they don't treat me like family. They say, oh, we're going back to your contract. I'm sorry, you don't have enough disability, you don't have enough PTO, you're not getting paid. And they treat you according to market norms. And employees hate that. They get really frustrated about that. So it's really important to be careful at which domain you're in. And as a trainee, there are thoughtful ways that you can navigate depending on which domain you're in. So for instance, if you're negotiating with your boss, who's been your service line chief and is going to be your boss, you're clearly in a social norm category, and you can take advantage of that to some extent. You can ask him things like, you can defer to him as your mentor and say, hey, I have really appreciated all the ways that you've helped me. If you were in my shoes right now, what are the things you'd ask for in this situation? And you're playing in that social norm category. You're deferring to him in his mentorship or her mentorship of you. And then you're forcing him or her to put themselves in your shoes and think about things from your perspective. And they're far more likely to advocate on your behalf. Also, they may say things or bring up things that you wouldn't even thought of to negotiate. Maybe salary isn't negotiable, but maybe you can get a signing bonus. Maybe they'll pay for a master's degree. Any number of other things that they may suggest that you hadn't even thought of. But there are a number of tactics like that you can do to successfully negotiate in that domain. But that overarching lens of those two different sets of norms really helps understand why there's so much tension and we feel so uncomfortable asking for those things in those kind of places.
Those are great little life hacks, I think, as the kids would say these days. Josh, very practical ways to navigate super awkward situations with your former residency program director or your fellowship director, who's then on the other side of the table in your first job. It's super, super weird. So it's very interesting. And I think that it's hard because there's no one really in academic medicine that can teach us that, because you can't really teach what you don't know. And you already made this point of most people in academics that are teaching don't know this stuff. So it's really hard to get those real life lessons. I'm curious, Jillian, are you seeing that trend? Maybe let me ask it this way. Do you see a big difference in those coming out of training versus coming to you in the middle of their career? Are they more comfortable negotiating? Have they broken some of those habits or maybe unspoken norms that Josh is talking about?
I would say, Josh, I wholeheartly agree with what you've said. And I do think you explain kind of the tension that folks are living in so well. I do see a lot of doctors later in their careers who have, for better or worse, learned more about the process. And sometimes, sadly, that's because they've been burned, because maybe it was a situation where they kind of bought into, I'm not going to worry about PTO. We're all family here. And then, the unforeseen happened and they realized they weren't, or, that their program director told them one thing and they left and that wasn't what happened, just any number of things. So that absolutely happens, that just over time and unfortunately over negative situations, you learn better. I think the situations where that really works out and everybody does treat you like family really doesn't prepare you any better for the next round of negotiations. But where you've had something kind of go wrong, I have absolutely seen that be the case. But it definitely tracks in terms of the conversations I'm having. Hey, the contract says that you'll have to work 40 hours a week and there's no protected admin time. And what I hear is, well, my program director told me I was going to have 8 hours. Okay, well, that's not here. Well, if I go back and tell him that, he'll think I don't trust him. And so they're in this tension of, do I come back to my mentor who has just offered me this money this contract attached to hundreds of thousands of dollars and say, hey, I don't really believe you. I'm going to need you to write something else here. And yeah, I understand how difficult that is. And just, again, I keep using the word, but kind of the tension that you're living in. I really, really like your approach, talking about kind of asking, hey, how would you suggest that I move forward? And I often give similar advice, which is go into this conversationally. I think the flip side of what we're talking about is that sometimes doctors are almost too aggressive. They're a little bit uncertain and they know the things that they do know. And so they kind of go in guns blazing, and it can come off a little confrontational. So something that I really encourage doctors to do is to look at these conversations as just that, conversations. Don't approach this as an adversarial situation. The example that I use is, maybe you want a larger signing bonus or a signing bonus at all. If you just send them an email and say, you've got to give me a signing bonus, and that's not something that they can do, then that conversation really ends. If you sit down at a table and say, hey, I've got a lot of expenses relative to moving, and I've got a family, and the contract as it currently exists doesn't really cover that. Is there anything that we can do to help offset that? Then they may go, you know what, we can't do a signing bonus, but there's this program through the hospital that you can apply for that'll get you X, Y, and Z. Or you know what, after year one, we might be able to get you some money for student loans or something like that. So if you really convey to them what you're actually looking for, as opposed to just kind of a line, in a list of things, I think it can get you further. And I think it can also use that relationship to your advantage, as opposed to letting it be a hindrance to you in the process.
And Jillian, since you've worked in health systems on the other side of this, can you give us a little bit of a glimpse behind the curtain? I mean, Josh has already talked about his negotiation with that first $5,000 increase they gave you on that salary, which is better than nothing. But
I think that puts you in the top 1% of physician negotiators, Josh.
Hey, that's great.
It's true.
That's
it's
okay.
True.
I mean, like, seriously, to Josh's point, like, we don't have, as doctors, much information on this. And yes, you worked at a health system, but probably the same information goes with your private dental offices looking to hire an associate, or a vet office. Like, what are most employers actually willing to budge versus where do you commonly see that having sat on the other side of the negotiation table?
Josh, I can tell you they were really happy when they got the response back from you, and what you wanted was $5,000. Because there is typically some pretty low-hanging fruit. One of the things that a common mistake that I see people making is wanting to bypass or ignore the recruiter. Sometimes there is the attitude of, like, this person can't really do anything. They don't really understand this. And they want to move on to somebody else. I think that's a huge mistake. Number one, this person can advocate for you. This person is very possibly, some of their compensation is tied to you joining. So they want this deal to happen, and they want you to be happy in that. So if there are things that need to go back to administration, they can advocate for you in that. There is also likely some low-hanging fruit that the recruiter can just say yes to, right? If you ask for a relocation bonus and there's not one there, he or she can probably just go, yep, we'll give you $15,000 and move on. So I think that's a huge mistake to make when negotiating or when kind of navigating the process. I also think that you want to understand the practice. So I think you're right, Michael. This does apply regardless of your practice type, but understand that if you're going to a private practice, you're probably not going to get protected research time, right? That's just not something that we see in those contracts. By the same token, if you're going to an academic center, you're probably not going to have a collections-based bonus. You have to sort of understand the world in which you are operating and what's typical for those things. Because sometimes I see, frankly, just sort of a lack of understanding on the part of the doctor. So, maybe they've kind of been told, hey, you're going to be paid based on RVUs. And so when that's not in their contract, well, I want to see that here. It's like, well, they're doing something different. And so you have to understand the offer and where they are fully before you can start kind of making those asks. So I think that's really important. The other thing too is to understand the market. And you all touched on this a bit, but you want to know if you're looking to move to an area, and I'll use the example of pediatrician, and there are 5 pediatrician spots available within the same city, you need to know that going in. You're probably going to have less room to negotiate. If you are a specialist looking to go to a rural area, you're probably going to have a lot more room, and you likely can get some more things and some more incentives that may not be there in other offers. So I think having an understanding of the environment of the employer, the environment in which the employer operates, those are really, really important things to be aware of.
You have to know what you're worth. And I don't mean what your mom says you're worth, or what the kind of care that you feel like you provide, or that you're a really caring or compassionate pediatrician, or that you made certain grades in school. I mean what you're worth in the market. You have to know what the normative salary data is, and the knowledge and skills that you bring, and the kind of income that will generate. And you need a realistic understanding of that. And your approach and negotiation tactics depend on where you fall on that spectrum. For instance, in my field of pediatric cardiology, if you're coming out and you're a cath doc and there's 2 jobs available in the entire nation doing what you do, you have no room for negotiation. You better just take what you're given and be grateful you have a job doing what you want. However, if you're heart transplant, heart failure, and there's 25 jobs, you're open to go into any of those places, you have tremendous room for negotiation. And that illustrates a principle that I think is important just to mention. It's called BATNA, which is Best Alternative to Negotiated Agreement. And anytime 2 parties are in a negotiation, the party with the stronger BATNA typically has more leverage in that negotiation. And so if I've decided I'm coming back to Arkansas no matter what, and I'm going to be a pediatric cardiologist, well, there's one group. And so I don't have a good alternative. I'm either going to take that job or move my family to somewhere my wife doesn't want to live, or be a pediatrician or something like that. I have a terrible BATNA. And then on the reverse side, as an employer, you have a BATNA. If I'm offering you the job, but I know I've got 20 other people that have applied for it, I've got a great alternative. If this falls down, it's go to the next person in line. If, however, I know that there's very few people with your area of training available, and if this falls apart, I don't have a good option, then I have a very weak BATNA. So having an understanding of both of those perspectives and where you fall, and then adjusting your negotiation tactics based on that. If you need to know from a poker perspective, the quality of the hand that you have. If you got a great hand, you play one way. You have a terrible hand, you play a different way. The same is true in our field. And so often physicians just jump in, either, especially, I think gender plays a role in male physicians. We tend to be more arrogant and have a higher view of ourselves, and be a little more aggressive in negotiation. So if you jump in and you think you're great, but you don't have a good BATNA, and there's lots of other people out there that have the same skills you do, like, you're going to get burned. Or conversely, if you bring skills that few other people can provide, and you don't ask for much, you've left a lot of money on the table. So recognizing where you fall in that spectrum, both from your perspective and the employer's spectrum, provides a lot of insight into how you should approach those conversations.
I could not agree more. I worked with a physician about a year ago, and this, what you said really reminded me of that situation. He had a specialty for which there is not a shortage. I'll put it that way. And he was very, very, very specific about where he wanted to go. And there was one employer in that area who was hiring. And he really hated the non-compete, which I agree was very restrictive. But he kept coming to me going, what can I do? What can I do? And I finally just had to have a really hard conversation and say, there's just really not a lot you can do. You can either sign this, or you can go and find something else. But you don't have a lot of options where you are. If this is where you want to practice, this is the option. And, you hate to tell someone that and to sort of have to deliver that news, but it's really important that you have that understanding, and that and again, sometimes that market, sometimes we're talking about, downtown metro area. It can be a really small area, but you really need an understanding of what that looks like. Otherwise, you're you could walk away from that and really not have anything else to fall back on.
Yeah, I mean, there's a disconnect within physicians themselves then. I mean, I'm going to use, it's a term that I knew it as, but it's kind of gross now in retrospect. But if you were to go into the match and submit a single site, a single center, I knew that as suicide matching, right? It was so ingrained into what you were going through as a physician that was seen as potentially deadly to your career. But then the same physician now, a couple of years later, is looking for that exact same setup and expecting to be able to be given everything. So it's kind of like a structural disconnect of, well, I'm here now. I've arrived. Like, please open your doors and shower me with flowers and laurels and things like that. And it's not the reality, especially if you're in an uncompetitive specialty. I mean, look, med peds is not a particularly competitive specialty. We're not particularly specialized within it. I've known this is something that we're going through. I want to come back to an issue that, Josh, you hit on, and Jillian, you also did at the beginning is, Josh, you specifically mentioned like an understanding of the current job market is critical. And then there's also the understanding of what you're worth. And those are two, I think, separate data sets and sources, or even multiple different data sets and sources. But I think it's a question for both of you, as you've been on both sides of this, like, where do you get the data from on a market analysis standpoint? And where does the data come from to educate you on your worth? So where as a doctor can I go to find out how worthy I am, or what value I would bring to a health system?
I'll speak briefly as an academic pediatric cardiologist, and Julian, I'm sure, can speak more broadly to the field. But there's a tremendous asymmetry with regard to access to this information. In my field, the primary data set is called the AAAP salary data, and it's what most pediatric hospitals use to pay for pediatric subspecialists. And you can't Google it. You can't find it out there on the internet. Only institutions have it available. So I actually called them, find out who at my institution gets it, and then I harass them until they give it to me. But those on the other end of the negotiation end, in the higher ups in the hospital, have access to that, and most trainees don't. So it is really hard, and I think that needs to change within our field. Each given specialty has a different data set. You don't get on Glassdoor and look up, what does the interventional radiologist make? That's not where you start. Doximity has a little bit of data out there. It's not that great. Medscape does, but your given specialty, will have a primary source for reliable salary data. And that's where someone like Jillian can be so valuable, because she can provide that, and she'll know what is reasonable, what's reliable, what to use in your situation.
Well, I agree with everything you just said, including that it can be really helpful to have somebody review your contract who does have some experience in the market. Whatever your specialty and whatever your practice type, there are surveys out there that produce this data. Now, I think you also hit on the really difficult part is, as a doctor, getting your hands on that information. It is not readily available, and it's not something that most doctors understand, even if they do have access. So even understanding when it says total compensation, what does that mean? What's included there? Is the valuation of benefits part of that calculation? All of those kinds of questions are answered differently by each particular data set. So you really need to know sort of what you're looking at. And what I tell doctors every time we look at that data is, this is the starting point. We don't ever sort of get the printout and go, okay, here's your number. That's where we're aiming, right? We want to say, hey, this is where the conversation starts. What factors are going to adjust this up or down? Are we looking at collections? Well, we want to then have information that tells us what the median collections are, what you can expect there. And then we can, work backwards, right? We can say, okay, if you're going to get a percentage, then what percentage do we think you could expect? That data can also help point out some red flags in the contract. I have worked with doctors before that maybe their RVU target or their collections target is significantly higher than the 90th percentile. Okay, then that's a problem, right? That we need to dig into that a bit more. Does that mean that they have mastered some type of efficiency that means you're just really going to be, churning them out? Okay, well, then let's talk through that. Is anybody else in the practice really there? Let's understand that a little bit better. So the data can really help us understand what we're looking at a little bit better. But again, I think you should really be cautious to treat that as the answer. So that's, to me, sort of the external piece of it. In terms of knowing your own worth, I think there's also kind of the really situation specific questions to ask as it relates to the job that you're looking at. How long have they been recruiting for this? If they've been looking for a GI doc for the last 18 months, you're worth quite a bit to that particular hospital system. If, you would join a team of 6 and, it'd be really nice to have an additional pediatrician. Maybe that's a little bit less. You want to understand where you are. If they're looking for a hospitalist, but they also have an internal medicine residency program at their institution, the likelihood of that maybe is not as great. You want to understand your value to them, but you also want to know what you bring to the table. If you're going to be opening a new service line to them, if you're willing to serve as a medical director in some capacity, if you're going to be a supervising or collaborating physician for mid-level providers, if you are bilingual or have experience serving a population that is that makes up a large percentage of their demographic, those kinds of things are significant. And I think while, again, you can't really find those on the data set, right? You can't really say, okay, where's the spot for bilingual who also grew up in this neighborhood? Like, that's not there. So you have to take the data and then apply your own set of filters to it, and talk through, where do I bump up a little bit and where does it come down a little bit? So I think it's a conversation to have. I think it's great to, again, have that conversation with somebody who is experienced in the market, but you really can't, like you said, just Google, what does a endocrinologist make, and go, okay, that's my number. It's not quite that straightforward.
That's amazing too. The point of, like, we're more than just a spreadsheet. Like, there's lots of other pieces of information that goes into the calculus, both for our understanding of our worth, but also on the employer side. I'm not an expert by any means. That's why we have you guys here. But one thing I think that's very common that I see with colleagues is only looking at one opportunity, not even applying anywhere else, not even talking to a recruiter. So going back to your BATNA, Josh, you have one job, one offer, you have nothing to fall back on, nothing to counter negotiate against. That's a very common thing I see. So there's one thing of not being able to even Google a data set, but it's another thing not even to have another job to bounce, rough ideas on things like signing bonus, call schedules, RVU goals, guarantees, those types of things. I mean, do you see that commonly, Josh, for the trainees that come to you in the hospital? They're only looking at one place, or maybe that was just my generation of trainees.
I definitely see that. I think there's an underlying issue that underpins a lot of that that's a little bit broader, and that relates to something called effective forecasting error. And so we do a very poor job predicting what will make us happy. We do a good job predicting this to make it happy or sad, the valence of that. We do a terrible job with intensity and duration. And there's a tremendous amount of psychological literature that sorts that out. And when picking a job in particular, we greatly emphasize variables that often have very little impact on long-term happiness. So in particular, we emphasize passion. And so we think, this is the one thing I'm passionate about doing. If I just find the job where I can do that one thing, then I'll be happy. And so there's only one job in the nation that lets us do that, and we let go of all these other things. When you actually look at the research at long-term job satisfaction, one really helpful lens to use is self-determination theory. And so the three primary determinants of long-term job satisfaction are autonomy, competence, and relatedness. Like, do I have control over my job and my life? And do I get to influence how things are done? Am I competent? Am I good at what I do in a domain that aligns with aptitudes in which I'm well trained and I do meaningful work and make a difference in the lives of others? And then the most important of those three is relatedness, the quality of our relationships with those we work with. And so those often get downplayed when we're making decisions. And so I encourage trainees often to look at what are the skills you can develop that let you negotiate for the job that gets you those three things. So I just had a conversation. I was at the American Academy of Pediatrics National Convention this weekend. And we had a group of fellows and we were talking about jobs, and all these attendings were giving all this advice about follow your passions, don't give up, keep doing research. I mean, when you look at decision-making literature, it was terrible advice. But I had one fellow at my table who's like, I'm going to be the one cardiologist. I'm going to do a whole fellowship in pediatric cardiology, and then I'm going to do palliative care, and then I'm just going to do palliative care to pediatric cardiologists. And I started asking, how many job opportunities are there around the nation like that? She's like, I don't really know, but I'm pretty sure I want to live in San Francisco. I'm like, so, and I asked her about how would you approach, what kind of RVU generation comes with that? She had no idea. And so we started talking more about that. And I said, well, are you making sure your echo skills are up to date? That's one of the big RVU generators in most institutions. They might let you do a lot of palliative care if you also read some echoes. And she's like, well, in my institution, you don't really do echoes unless you do a 4th year, an additional imaging fellowship. And so we had a long talk, and she's emailed me like 3 times since then and is asking for more data on salaries. And we've had an ongoing conversation. But that kind of perspective is almost never provided to trainees. It amazes me in medicine. We talked about practicing evidence-based medicine over and over and over again. But when it comes to living our lives, we don't actually know the research. We're greatly influenced by American culture and things like Disney movies and what some influencer might say with what we think actually provides happiness. And there's tremendous research out there that clearly defines the things that really make us happy in the long term. And I would encourage all the listeners to spend a little bit of time, read some of that literature, and then structure a negotiation in a way that allows you to emphasize and prioritize the things that are actually likely to make you happy.
So on a really practical level, I have seen that play out so often. And where I see it most frequently is around the schedule. So I'm talking to these people who, a lot of them have just finished training and they have put years and years and years and more dollars than I want to think about, and all of this effort into this. And I'm like, okay, so how many hours a week are you going to work? And they're, almost offended. They're really taken aback. And like, that's, not what this is. And everybody pitches in, when I hear all of these things, well, what about call? Well, I think it's probably only going to be X, Y, or Z, and they just have all of this vague language about it. And I tell them so often, this is going to be the thing that matters to you, right? You think you're going to have every Friday off. If you get there and you don't, you're going to be really upset about it. You're not going to, if you think you'll have one weekend a quarter and that becomes one weekend a month of call, that affects your quality of life. And nobody wants to talk about it. It's not sort of the interesting, deep, meaningful contract negotiation issue, but it is so frequently the thing that really gets people hung up, because then on the other end, they come back to me and go, I've got to get out of this job. I'm taking call all the time. Okay, well, what did your contract say about that? Well, it just says I'll take call when they tell me to. Okay, well, then we could have avoided this, right? So, it's absolutely true that everybody kind of wants to go after these big, lofty issues. I want to talk about indemnification. Okay, great. I see a schedule matter 100 times more than I see indemnification matter in a contract. Not to say that they're not both important issues, but it's those really nitty-gritty day-to-day things that are going to matter. And I have a hard time convincing people to care about those in their contract.
Well, I think about, Josh, what you said of like the passion, follow your dreams. And no one really writes their med school or dental school or vet school application as like, I want to make a really good salary and find meaning. And those three things that you mentioned, I don't think they would get into any school, which you're rightful, to a degree. Like, okay, we obviously care about what we do. We care about patient care. Otherwise, we probably wouldn't do this. But at the end of the day, it is a job that you need to perform a duty or a task for and get paid for it. So there's aspects of that you have to navigate. And I think that goes back to a couple of things both of you guys have said is, one, we're not used to doing this. Two is we feel guilty because if we treat it as a job, market norm, then that's not going to be treated well within my training program because this is a passion. This is not just a job. And if you ask those questions, it's not necessarily going to be looked upon favorably and then used against you potentially later when you're asking for a job at that same institution. I did want to say something, Ned, to you, though. You talked about specialized in internal medicine, and I just want to tell you that I think you're special, and I think MedPeds is special. So I don't want that to go lost on our listeners.
Use that in a negotiation, Dad. Tell them that Michael said you were special.
You mentioned earlier that like it's what our worth is, not what my mother thinks my worth is, nor what Michael thinks my worth is. I need an objective data set here.
That's got to be worth something, hopefully.
So I want to go back to some of the negotiation tactics because you mentioned BATNA, which is a great one. We talked about adding other things to the negotiation pod and not getting stuck on any one thing. But how specifically can you negotiate the challenges of that awkwardness, right? If you're a passionate, driven individual negotiating against somebody who's been variably either a boss, a mentor, a disciplinarian, how do you negotiate that kind of that awkward dance between the social norms, the market norms, and again, the field of medicine itself when it comes to this kind of hierarchical structure?
Well, one, it is difficult, but there are a couple specific techniques you can employ. One in particular is to utilize a non-present third party and basically blame things on them. So in the absence of someone like Jillian,
we bring Jaco into the conversation and blame everything on them, right?
Or what's often the case is you can bring your spouse, a discussion your spouse into it to say, hey, I'd love to stay here. This would be a great fit for me. If I come home and tell my wife that I took this job at the 25th percentile, she's going to kill me. Like, please, and then in the social norm category, that's a reasonable request. Mm-hmm. And you're not saying, hey, this is ridiculous. Why are you making me this offer? That's an inappropriate thing to say in the social norm category. So you could utilize a spouse, or even better, someone like Jillian, that you can hire someone like Jillian who can give you non-biased advice that comes from a place of knowledge and expertise. And then you can come to your boss and say, I really want to stay here. However, Jillian, who has reviewed everything for me and is really an expert in this space, has said, there's no way I should take this offer, that it would be inappropriate for me to do this. And you can maintain your relationship with them while blaming a third party. And that's, I think, one of the greatest benefits of hiring someone like Jillian. There's a lot of others. Obviously, we don't have training in this area. She has tremendous knowledge. But just from a pure psychological perspective, that's a huge benefit to bringing someone like her on your team.
I really appreciate that. And I tell doctors that a lot, make me the bad guy. I am more than happy to be the one, like you said, tell them that I said you can't possibly sign it without asking for a signing bonus or, whatever that looks like. So I think that's absolutely right. Having somebody review your contract not only gives you more information, but it also kind of gives you a cover to say, hey, this person's really kind of forcing the issue here and saying, I've got to dig deeper.
One of the things I do as a mentor is I let trainees blame me because most of them aren't hiring someone like you, Jillian. So I just tell them you talk to Dr. Daly, and everyone knows I'm kind of the finance expert, and that he said you have to do this. It'd be ridiculous for you not to. And then if they're going to their boss and then I'm their colleague who also mentors them, that's understandable within the social domain and accept it in a way that's just, it's not to just make a request yourself because you feel like you want something. And there's a related principle that's just worth mentioning. If you make a request, if you have any rationale for why you're making that request and you articulate it, you're far more likely to receive it, even if the rationale is only loosely related to that. Don't just, like I did, don't just ask for $5,000. Come up with some rationale. It could be something as simple as, man, this sounds great. I just had my second kid. We're going to be moving down there, have a lot of additional costs. Would you be willing to increase my salary by 10,000? It's more likely to be received, especially in the social norm category, than me just saying, hey, I want more money. So always couple a request with some rationale for why you're making that request. And that can be based on data that someone like Jillian provides, or unique variables related to your personal situation.
I think the other thing it gives you the opportunity to do is let them know that you are educated about it when you come in and say, hey, I've talked to Dr. Daly and this is what he suggests, or I've talked to an attorney and this is what she suggests. Then that tells them, I understand what's going on here, right? I understand that this $10,000 signing bonus is actually pretty low. And we're going to need to up that. Or I know that you're offering me the 25th percentile and that's a no-go. I think that employers are also aware of a lot of these things that we're talking about, and they're also aware of the imbalance of knowledge and the imbalance in negotiating power, and they're willing to use that to their own advantage. So when you kind of say, hey, I've talked to somebody and they think I need to ask for X, it tells them, okay, this person is doing their due diligence.
And changes the level set then of the game, right? And who they're going to approach and how I think they'll approach the negotiation, which I think is absolutely brilliant. I like the non-present third party to blame it on. That's a good, we have it used against us all the time. I joke around. I was joking about Jaco at the beginning, the number of things that are allegedly because some regulator or policymaker wants it a certain way. So what is one thing that you've changed your mind about recently? It's a tough question. We'll give you a sec to think on it and chew on it. It's a tough question on purpose. So who wants to start?
That's a very tough question, and not one that a lawyer really likes to answer. So you're really putting me to the test here. I will say that the thing I've changed my mind about recently is what I think the future of non-competes looks like. I'm sure most, if not all, of the listeners here are very aware that in the spring, the Federal Trade Commission issued a new rule essentially doing away with non-competes. It immediately was challenged in a couple of different states, and we kind of had to wait through the summer to see what that was going to look like. And I was really convinced we were going to see a pretty big shift. You're seeing it at a lot of state levels. There's just a lot of movement and a lot of sort of public policy momentum. And I thought, this is going to be it. Like, we're really going to do it. And that rule has now been enjoined in one federal district court. It is under review in another federal district court. And looking at the opinion as to why the court in Texas said, no, we won't enforce this, and looking at some of the other cases that the Supreme Court has ruled on recently, I am now changing my position, and I don't think it's going to happen. Unfortunately, I wish that it was, but unfortunately, I think we're going to be stuck with non-competes a little while longer. Okay.
Which we could do a whole other episode on non-competes in healthcare and what that, frankly, how that specifically excluded certain areas of healthcare, for-profit healthcare too. So there's not for profit.
A lot to unpack there. But the short answer is, we probably do need to do an episode because I think they're going to be around a while.
Which is also good news, good advice, and a good shout out to a future episode where we have you back to talk about non-competes, Jillian. Josh, how about you? And does it relate to non-competes? Yes. Okay. All right.
By far, the area of my life in which I have been humbled the most frequently and changed my mind the most is the area of parenting. If I thought back about the version of myself from 10 years ago and the advice I gave parents who had various kids, and then if that version of myself looked at the way I parented now, I would have been very judgmental. And I would have given myself lots of advice about what I needed to do differently. Most recently, my perspective has been influenced a lot by the book Anxious Generation by Jonathan Haidt, which I recently finished reading. And in particular, thinking my oldest is 13, my next is 10, and thinking about the things we say yes and no to, where we protect them and where we let them struggle. and recognizing that Americans as a whole, and us in particular, have been far too risk tolerant in the virtual space with regarding devices, internet, video games, et cetera, and the tremendous consequences of that, and far too risk adverse in the physical world. That we won't let our kids play outside. We're worried they're going to be kidnapped. These bad things are going to happen. And there are tremendous consequences for that, especially as they transition to adulthood. So we're wrestling in our own household, even though in many respects, I feel as though my kids are so immature and do not deserve these additional freedoms outside the house. Letting them go and play in the creek, letting them play a football game out in the yard and get in a fight with the neighbor and sort it out themselves, letting them risk falling and breaking a bone. Like, yeah, that's a pain that day, but in the grand scheme of things, it's not that big a deal. Letting them walk to school, letting them walk to a restaurant and order food on their own. And do these things in the physical world that they may struggle initially, but are so important for their development. And especially as a pediatrician and someone tends to be hesitant of risks, I tend to view the worst and put a lot of rules up around that. And I am recognizing that I really need to let go in that area while really holding the line in the area of devices and internet access. So that's an evolving topic, and one that my wife and I continue to struggle with. And probably in 5 years, I'll have a very different take on it. But at the moment, that is an area that I just recently really changed my mind on.
Well, that's wonderful.
Well, I love that. I mean, basically, Ned and I asked that because we all consume so much information and data all the time, but how much do we actually let it influence our opinions on something and actually shift an opinion? So I love hearing about that for both of you guys. Before we wrap up, I did want to ask Josh, where can people find out more about a lot of the work you do, especially on personal finance and in the doctor space, educating our community?
So one, you're welcome to email me. And if you just Google my name and UAMS, it comes up. That's probably the easiest. I have written a number of articles in the academic space. And for those who are familiar with PubMed, if you PubMed me, a number of things come up as well. At the moment, the material we have in our course is not publicly available, although I would really like to make that change so anyone can watch the various videos and educational material that we create, and that should be coming relatively soon.
Excellent. Awesome. And Jillian, for all those doctors out there that need advice on their contract and want to talk to you, how should they find you? What's the best way to find you?
Anybody's welcome to email me. My email is jillian.vestal@panacea.legal. And you can also find me on our website at panacea.legal. There is some more information there, and you can fill out a form to get some more information or sign up for a review. All of that is on our website.
Awesome. Well, thank you guys for joining us. Really practical, hands-on information that hopefully people find useful, and I'm sure we'll probably be re-engaging for future episodes. So thank you for your time.
Man, Ned, what'd you think? That was really informative and stuff I wish I had known coming out of residency.
I really wish I'd had the opportunity to take a listen to this information or get access to this information, or frankly, even had people like Josh and Jillian available to me to answer these kind of questions. I talk about a world of where I did not know what I did not know. And just in general was just trying to keep moving forward. So I love that conversation, and I really appreciated the tangible takeaways about how doctors can protect themselves as they're going through transitions in their careers and new jobs and new negotiation tactics.
I do think it's interesting, Josh, or Dr. Daly is kind of viewed in his program, as he mentioned, as like the go-to. Hey, if you got a question about contracts or compensation, you go talk to Dr. Daly. And everybody, I think, has one of those, hopefully, in their program or sphere of training. Is like, there's that one person that you want to go talk to if you have a question about finances or contracts. But at the end of the day, it is a doctor who brings that experience and know-how, but isn't the attorney in this case. And so I think it's important to balance that out if you can. The other thing is, quite frankly, I know this with Josh to be true, is that he doesn't have enough time to actually go through every single person's contract and talk about negotiation and employment opportunities or fair compensation, non-competes. Like that, he can offer guidance. Those people can offer guidance in your sphere, but it's nice to couple that with someone who actually has that as their vocation.
Completely. I mean, look, Josh has become an expert by looking at probably hundreds of contracts, and can't say that how that speaks to his character and quality and why he's always been such a friend to both of us, frankly. But you then look at somebody who's a true specialist in this, and they've looked at thousands. And so there's just like gaps that are going to be there if this is not what you do all day, every day. And so, like you said, that marriage, the ability to have somebody in your corner who understands healthcare and understands, frankly, in his world, something as hyper specific as pediatric cardiology and the nuances associated with it. And then also understands then somebody else who understands the nuances of contract law and the fact that there's 51 different governing states for contract law and what that all means. You need specialists, right? Like you wouldn't take this type of question to a generalist. So it's really nice hearing them connect and communicate about the ways in which they assess these issues for their training doctors.
Yeah, and I think the more information doctors have, the better decisions we can make, the happier we can be in our practice, and then the happier we are in our practice, the better patient care we can deliver. And so right now, there's just such a big power dynamic, I think, in employers, what they know as far as data goes, what's fair, what's not fair, versus the individual doctors who are kind of siloed on specialty and on program, geography, and the employers take advantage of that. I'm not saying it's malicious, but that's just the way that business might go.
Information asymmetry. Yep.
Yeah, it's information asymmetry. And so the more doctors can be equipped with information, not just on negotiations and contracts, but lots of other things, I think the better our healthcare system can be. It's just, we're very busy and we can't be experts at everything. To your point, we need specialists that actually know what they're talking about and not just trying to take advantage of us. And so it's great to know resources like Jillian are out there to help doctors.
Absolutely. So thank you, Dr. Daly. Thank you, Jillian, for joining us. And thank you to all our listeners. I appreciate you guys hanging out and learning about contract review with us.
All right. We'll see you next time.
Thanks for joining us this episode. You can catch the podcast For Doctors by Doctors on Apple, Spotify, YouTube, and all the major podcasting platforms. If you enjoyed this episode or learned anything here today, please take a moment to give us a rating and subscribe so that you don't miss a single episode release. As always, thank you for listening. The next time you see a doctor, maybe you should prescribe this podcast. We'll see you next time.